Tomorrow you will receive a link to this recording as well as the PDF presentation that we'll go over today. We'll also post the recording and the presentation on our SharePoint site. In order to minimize background noise, your phones are actually muted in a listen-only mode during the presentation. We will have a Q&A period at the end of the webinar, so please feel free to use the chat function to send those questions, but also send your questions at any time during the presentation as they arise. You should see a chat dialog area located on the lower left-hand side of the screen where you may type and send questions. You will also see a raised hand button, which we will not actually be using today. So you don't need to click it when asking a question, just use the chat functionality. If you have any technical difficulties during the webinar, we are using the ReadyTalk platform, and their toll-free technical support number is 1-800-843-9166. Again, 1-800-843-9166, and make sure to have your registration confirmation available. And then finally, when the webinar is concluded, you'll have the opportunity to give us feedback through a short survey. We ask you to take a minute and complete the survey, which will help us improve future presentations. And with that, I would like to introduce Rebecca Goodman. She's a senior attorney specializing in adolescent health care. Rebecca is author of numerous articles and papers on consent, confidentiality, and information sharing law, and trains nationally on these issues. She earned her BA from Harvard in 1990 and her JD from the UCLA School of Law in 1994. She also holds a Master in Public Administration from Harvard's John F. Kennedy School of Government. She began her career with the Children's Rights Project at Public Counsel in Los Angeles, where she created Public Counsel's Teen Legal Clinic program. In 1997, she was named the American Bar Association's Young Lawyer Child Advocate of the Year. So without further ado, I will turn this over to Rebecca.
Thanks, Dara. This is Rebecca. Hi, everyone. Good morning. It's a pleasure to share some time with you, and I thank you for joining us. I just want to warn you up front that I am a lawyer, and so no doubt some things I say will frustrate you, and my answers will frustrate you because no matter how hard I try, I still end up talking lawyerly sometimes. So please do take advantage of the question box, and we will, if I can, I'll try to touch on questions as they come in, but some, even if I sort of don't find a place to hit it during the presentation, we'll make sure we go back to that at the end and have some good conversations. So just to kick things off, we actually wanted to start with an audience poll to find out sort of where folks are. So our question to you is, do you currently provide portal access to patients in any of the following age ranges: 0 to 12, 13 to 17, or 18 and older? So on the slide that you have in front of you, you should be able to click any of the three. If you don't provide any portal access at this point, then just leave it blank. And you should be able to see some of the answers popping up on the side of the slide. So we'll just sit here for a second and give folks an opportunity to respond. Thus far it looks like there are some folks who are already providing access to some portal services to 13 to 17-year-olds, more to the adult population. Okay, so far 10 say 18 and older, 4 say 13 to 17, 1 0 to 12. Well, it's great to see so many folks are already using portals and even providing access to the minor population. Okay, so at this point we have 10 folks who say they're providing access to 18 and older, 4 said 13 to 17, and 1 said 0 to 12. So that's great. We're already talking to, it sounds like, a very savvy audience, and so I appreciate that. And I'll just say bear with me as we sort of walk through some of the basics. I think it's still important to do that before we get to some of the more complicated questions. We need those building blocks in place, but I'll try to do that relatively quickly so that we can get to the sort of the practical questions. So just as an overview of what we're going to cover in the next hour, we wanted to do a little bit of framing of sort of why portals can be such a valuable tool, and particularly with a younger audience. And then we'll spend a good chunk of time talking about the law, about the security and privacy rules that you need to be aware of and build into any portal that you create. And once we've sort of gone through those building blocks, I will be turning it over to the fabulous Tom and Jim to talk a little bit more about how do we take that and use it in planning and implementation. And at that point, I know we have folks sort of at a lot of different stages, and so Tom will be talking about sort of addressing the different needs, recognizing that we have folks at very different stages of the process. And as we said, there will be time at the end for a Q&A. Just like as I warned you up front, I'm a lawyer, so here's one of our little lawyer language. I did want to flag, I will be talking about laws. It's a lot of legal information, but I'm not allowed to provide legal advice. So a lot of the information provided today is stuff that you may be bringing back and speaking to your own legal counsel about application in your particular context, because we have folks providing such a wide range of healthcare services in different kinds of contexts that it would be really impossible to try to do something that answers very specific application questions. So wanted to just flag that. But now let's jump into our content. So this is sort of a gimme slide, but let's just put out there, how do we encourage access to healthcare and better outcomes for adolescents? Make sure they come in for services, and when they get in that door for services, that we actually see positive results in return. How do we foster engagement of adolescents in their own healthcare and get them to connect and care? How do we provide a tool that supports conditional confidentiality? And I'll talk a little bit more about what I mean by that, but for those of you who work with adolescents, you know that confidentiality, and particularly when we're dealing with younger people, isn't an absolute, and it can be really tricky navigating sort of the exceptions. And how do we find a tool that lets us, in a more efficient and easier way, achieve the requirements that federal law puts on us regarding health information? And as you can imagine, at least one answer, which I would suggest to you today, is using an online portal. And I just want to dig a little bit more into some of the bullet points that we have up here before we talk about application, because I do think it's worth the effort, and that's what we want to talk about now. So there's actually been decades and decades of research with young people about how do we connect them with healthcare services, how do we make sure that they get the healthcare that they actually need. Interviews and other surveys to find out how they think and feel about healthcare. And the great news is that overall, adolescents report a willingness to talk to healthcare providers about very sensitive topics, including relationships and violence. They consider healthcare providers trustworthy. They're ready to go in and believe in you, and that's a great opportunity to create relationships that can lead to better outcomes. But what adolescents and what all this research also tells us is that trust and confidentiality are critical to care seeking for adolescents, and I'll talk a little bit more about that in a second. But the other thing I wanted to flag is that when we look at adolescent development, and I'm not a social scientist or a scientist, but looking at all of the research, as a normal part of adolescent development, it is appropriate for teens, even starting in the middle school years, to start to want to pull away, to create their own identity, to create their own independence, and that's where some of this privacy seeking comes from. It's a part of normal adolescent development. It doesn't mean that we absolutely let them fend for themselves, but in a safe way start to create spaces where they can take some ownership is a healthy way of helping them not only right now, but as they grow into adults and who can positively advocate for their own health care. But as I said, I wanted to dig in a little bit more into some of the research. This is just one example, but we have truly 30 years of research telling us that privacy concerns can actually prevent teens from going in the door of your clinic in the first place. Just one example was a survey of family planning clinics in the Midwest, and clients were asked, if your parents were to be notified that you were here, would you still come in for care? 50% of the sexually active girls who were attending the clinic said that they would stop using the clinic if their parents had to be notified. But notably, only 1% said that they would actually stop having sex. So need for care is still there. Their willingness to come in and see you in that first instance is dropped in half. We also have research that tells us even when teens walk through that door in the first place, what they say to you and how much they're willing to disclose will be influenced heavily by the privacy and trust relationship. And so feeling like this is a safe space, a confidential space, can be really important, particularly when you're trying to suss out sort of youth who are involved in really high-risk activities or who've been involved in relationships that are dangerous. This is the kind of thing that they look for those cues, and you may or may not hear what's going on depending on the kinds of confidentiality tools you have in place. Now, with all of that said, we also have a lot of research that tells us that the great majority of teens actually will involve their parent or caretaker in their care, but they want to be asked. They want to know that they have the option to say yes or no. And what's interesting is, as we look at ages, the younger youth are even more likely to involve parents in their care when they're given the option. The 17-year-old slightly less. But it's reassuring to know that most youth do want to involve an adult in their care, but that key is wanting to have that authority to say yes or no. Okay, so that all of that sort of suggests to us that portals, to the extent that they could help us create and maintain tools for confidentiality, can actually help us connect kids with care. Conditional confidentiality. For healthcare providers, you know well that confidentiality is never an absolute thing. Nobody can walk in the door and you can guarantee them that no matter what happens or what's said, nothing will ever leave the room. That said, when we're talking about young people, the conditions, the limits on confidentiality are much greater. You have child abuse reporting obligations. You have reporting obligations when someone discloses that they may be a risk to themselves. There are a number of confidentiality laws that require you to keep certain information confidential, but require you to inform parents about other information. A lot of conditions. And an electronic system can actually help you keep on top of these conditions, where in the past we had to rely on our memory or rely on that one person in the office who seemed to always be on top of what the newest conditions were, what the newest laws were. So in that sense, a portal can actually help facilitate maintaining confidentiality where appropriate, and triggering and reminding you when a condition may be in place that requires you to notify somebody about something that's going on. Excuse me. I thought it might be helpful to bring you some research specifically addressing portals and the interest of youth in using portals. In this study, youth ages 16 to 18 and their parents were interviewed about portals and different aspects of portals to sort of try to suss out their interest. And what the research showed us is that generally parents and teens were very enthusiastic about the idea of some sort of online engagement with their healthcare providers. I've put a couple quotes up here from the research, but I've also put the site to the paper if you want to look and see a little bit more. But just a couple examples. One teen said, "Putting teen healthcare online will bring teens one step closer to taking control of themselves." Another teen said, "Parents are the enemy when it comes to our private lives. We need to feel we have control of our lives." And that teen went on to say, "A portal can help us feel like we have some control." Another teen said, "This creates a relaxed mood, which makes the doctor more approachable." And several said that they would feel much more comfortable approaching or asking questions online than they may during a visit. In that same survey, they asked which aspects of a portal were interesting to them. And the components that they flagged as most interesting were using the portal as a way to get health information and education from a reputable source. So both the parents trusted that their teens, if their teens were going online and looking for information, that they would get good information if they went to their provider's website. They all flagged online appointments as a great tool and valuable one. They said that they'd be interested in getting lab results and personal health information online. And they also, in particular the teens, flagged secure messaging as something that they were very interested in. And we'll talk a lot more about the different components that you may or may not want to include in a portal later on, but it's interesting to see that they had flagged all of those as interesting to them. I also wanted to flag another study. This was a study with youth who were detained in a juvenile hall, ages 13 to 18. And I think it's really interesting because it shows us that even some of our most vulnerable youth who often have a lot of barriers in place to getting care are quite interested in using a portal and see it as a valuable tool. So in this study, again, they surveyed youth 13 to 18 who were currently detained in a juvenile hall. 90% said that it would be really useful to them to be able to access health information via the internet. Notably, 97% of them said that they had accessed computers or the internet at least once in the last month, and 87% said they had at least in the last week. And again, these are kids who were in juvenile hall, so you would imagine their access is somewhat more limited. 42% used mobile phones to access the internet, and 100% said that they did have access to some sort of a PC somewhere, either at their home or at a friend or relatives. So that's really encouraging to see that a portal can be a tool for sort of all sorts of populations, including underserved populations. And there is a lot of other research showing us that there is actually quite high levels of computer and internet use with other underserved populations, including even homeless youth, which is great news. Now, one other component that a portal can sort of help us to achieve is actually meeting some of the obligations imposed by federal law. And here is just one example. The HIPAA security rule requires covered entities to ensure that if you have electronic health information, that information is accessible and usable upon demand by an authorized person. Now, it doesn't require a portal, but certainly a portal is a tool that can help you meet this obligation in a way that may be easier than other mechanisms to ensure that folks have access to their info. Okay, so with all of that said, with all the research, we're back to another audience poll. Our question now is, which features of a patient portal are you currently providing or considering providing to minor patients? So I know many of you already have stuff in place for adults, but which of these are you providing or considering providing to minor patients? So again, we'll just take a little bit of time, give you a chance to check. You're allowed to check more than one box. Okay, it looks like there's interest in all of these, maybe a little bit less in online appointments, a lot of interest in health education, personal health information, secure messaging. Okay, great. So lots of interest in providing health education or information, definitely in messaging and providing personal health information, and interest in online appointments, but perhaps a little bit less. Okay, so now we're actually going to start doing some of the law. Now, it's interesting to see how many folks are interested in the secure messaging and personal using the portal as a tool to convey what would be personally identifiable health information, because a lot of the legal rules really only are triggered. You only have to worry about them when your portal is going to be used to convey individually identifiable health info. So I'm going to keep coming back to that, but I wanted to say it right up front. What we're going to go through now are what I call the 3 Ps of patient portals: the legal parameters, the practical application, and principles, sort of 3 components as you're thinking about what you might want to do. The legal parameters really are what we need to keep in mind when we may be conveying individual health information. So, HIPAA security rule applies to all electronic personal health information. That means individually identifiable health information. If what you're conveying does not include individually identifiable information, you do not need to put all of these security rules that I'm about to talk about in place. For short, we're just going to call that EPHI, but it's really important to remember we're talking about individually identifiable information. As a very general matter, what the security rule says is that when you do have EPHI, you're required to ensure the confidentiality, integrity, and availability of that information. Availability means that the data or information is accessible and usable upon demand by an authorized person. Confidentiality means it's not available or disclosed to unauthorized people. And excuse me, I'm starting to lose my voice. Integrity links back to some technical rules, which we'll talk about in a second. But what I want to flag is this term authorized person. And we are actually, you know what, I'm going to just keep that in mind. But just as we look at some of the tools that we talked about with the portal, which of these might contain individually identifiable information? Portal is a source of health info, maybe, maybe not. Online appointments, it depends how you're doing your online appointments. If you're segregating appointments so that someone has to pay, in simply making the appointment, they're effectively disclosing the type of health care they'll be looking for. Is that disclosing individually identifiable information? Lab results and personal health information are certainly individually identifiable. Secure messaging is. This is the kind of questions, though, to go back with your own legal counsel and team and sort of say, which components do we have in place that may be involve individually identifiable health information? And to sort of put this into even more concrete practice, I'm going to present you 2 cases right now. I want you to just keep them in mind as we go through the rest of the security rule, and we're going to come back to them. So the first case is Joe. Joe is 17, and he and his mom came to your clinic for Joe's annual physical. He has his physical, but during his private one-on-one time with his clinician, Joe says that he would really like to get a confidential STD test at your clinic. The clinician performs this test and sends the samples to the lab. An email is sent to Joe a few days later to tell him his results are ready and asking him to make an appointment to come in and speak in person about those results. He is also directed to some online anticipatory guidance regarding sexual health. So we've used the computer, we've used portals here. What components of this are involving electronic information? What obligations do we have under security and privacy rule? We're going to come back to that after we've looked at those rules, but so just keep Joe in mind. Our other case is Miranda. Miranda's 12, and she's receiving mental health counseling at your clinic. During a private conversation with her clinician, she reveals that she gets really anxious during her father's frequent angry outbursts at Miranda's mom. She says her parents have split up and she now lives with her mom and grandma. Dad has now called your clinic to schedule her next appointment and to ask for a copy of her file to send her school. So here we haven't explicitly flagged a portal, but we'll come back and talk about sort of what different portal components might mean when you've got a scenario like Miranda's. Okay, so we introduced the broad security rule. We flagged that we need to, the key question is involving individually identifiable ePHI. When we are going to be have ePHI available, we need to know three things. We need to know when an adolescent is the authorized user of his or her own information. We need to know when a parent or another adult caretaker is an authorized user of his or her child's information. And we also need to know when providers have discretion to authorize or refuse to give access to ePHI, either to the caretaker/parent or to the youth, because this is one of those things that, unlike adults, there's a lot more places where providers may have discretion to turn on or off the authority of a user. So who is that authorized user? How do we answer those three questions? What the HIPAA security rule says is we go back to the HIPAA privacy rule. And whoever the HIPAA privacy rule says is authorized to get the information, that's who has the rights under the security rule, the right to have information made available, the right to have information excluded from unauthorized users, the right to turn on or off access, the authority to turn on or off access for third parties. So what does the HIPAA privacy rule say? The HIPAA privacy rule generally protects the confidentiality of health information, but what it does is it sets a basic floor for confidentiality and says at a minimum this is sort of the minimum standard. It then says if your state law provides greater protection for health information, then you should follow your state law. So HIPAA is a floor. Your state law, to the extent that it provides greater protection, becomes the controlling rule. So when we're looking at the privacy rule in Colorado, we need to look at what the HIPAA minimum floor is. We need to look at Colorado statutes and figure out which one controls in which context, depending on the privacy protections that they provide. And it's important to know that there are other federal laws that may apply in addition to Colorado and HIPAA or in lieu of HIPAA. And one example would be federal drug treatment laws that protect the confidentiality of certain drug treatment records. If drug treatment records fall under the protection of that federal law, that really is determinative. So depending on the clinic that you're in and the types of services you provide, that may be more or less relevant to you. Okay, so reading all of those together, we can find out who can authorize access to adolescents' records, when parents have access, when providers have discretion authorize access, and when parents have a right to access. So I actually want to start with who can authorize the release of an adolescent's health records. What HIPAA says is that the right to authorize the release of records, so the right to give permission to others to see records, usually is based on who consented to the care. And that means if a parent consents for an adolescent's medical care, the parents need to sign that authorization in order to disclose records to others, in order to give other people permission to see the records. But if a minor consents for his or her health care, it's the minor who needs to sign an authorization to release records to other people. Now we'll talk in a second about when parents have a right to see it, but to the extent that you have within your portal or you're considering giving users the ability to authorize third parties to see records, this is the kind of this is who would be authorizing that kind of disclosure or permission to see. So it's critical that we know when minors can consent for their own health care. In the handouts that you received both a document called the Understanding Minor Consent and Confidentiality in Colorado Toolkit and a pullout from that is a chart with minor consent laws. We're going to be referring back to those. You don't need to have them open right now, but I just wanted to flag right now that the slides that we're about to do are a quick overview, but you have a lot more information in the materials you've been provided. Now, in general, every state has laws that allow minors to consent to their own health care in certain circumstances, and you can divide those into two types of laws. Laws that allow minors to consent to care based on their status, their situation in life, and laws that allow minors to consent to health care because of the type of service they're seeking, because we've either think that this is a really important service or that youth may be loath to seek the service without having some privacy involved in it, different reasons, but it's service specific. So let's look at Colorado's status exceptions. Minors in any of these categories can consent to their own medical care, general medical care, if they're married or divorced, and that includes folks who may have been married in other states or other countries, as long as it's a legally valid marriage wherever it took place. But you may have folks that come in and tell you they're married and they never actually performed a legal marriage. It's really important to know. Minors who are in the youthful offender system are allowed to consent to their own medical care. That's a very specific exception, and to the extent you think this may be relevant to your client population, I urge you to just take a look at the chart and get a little bit more detail about that. The one that's probably most relevant is that minors who are 15 or older, living apart from their parents and managing their own financial affairs, are able to consent for their own general medical care. And again, this is important to us because whoever consented for the care has the legal authority under HIPAA to sign releases of information to give you permission to disclose that those health records to others. Now, in addition to these exceptions, we have exceptions that allow minors to consent based on the type of service. Now, this one may not be relevant to everyone, but to the extent that you're providing Title X, Federal Title X funded family planning, Federal Title X requires that minors be able to consent to that, to those family planning services on their own. Separately, Colorado law allows minors to consent to birth control supplies, procedures, information on their own. Abortion, I'm not going to go into a lot of detail about that. We have some notice rules around that, but minors actually do have the ability to consent. Diagnosis and treatment for STDs, mental health treatment for minors 15 and older, treatment for alcohol or drug use or abuse, exam and treatment after sexual assault, and I put it twice, sexually transmitted infection diagnosis and treatment. So as I said, this is just a quick list. You can look at the chart for more details and actual citations back to the statutes that authorize this. So when is a youth an authorized user of his or her health information? Because remember the security rule, we need to know who the authorized user is. A minor generally has the right to access health information about him or herself when the minor consented to the health care, and a minor generally has the right to control release of the information when the minor consented to health care. When does a parent become the authorized user of a child's health information? Generally, a parent has the right to access health information about their child when the parent consented to health care. So certainly when we have younger youth, that's important. And for many of the services adolescents would be seeking, the parent still is consenting to care. And when I say parent, I of course mean caretaker, guardian, other legally authorized caretaker of the minor. But when it comes to parents, there is a very important rule that says providers can always refuse to give parents access to records where the healthcare provider has a reasonable belief that the minor has been or may be abused or neglected by the parent, or where allowing access to those records might endanger the minor and the provider determines through an exercise of professional judgment that providing access is not in the minor's best interest. So that's a lot of language to digest, but the bottom line is parents' right to access records is never absolute. There is always this ability to exercise discretion on the part of the provider who's providing services and make a judgment call that in some contexts parent access may not be appropriate. And that's going to be really important to think about when we get to portals and sort of thinking about on-off switches and what's available online and sort of who controls access. So let's go back again to with that in mind, let's go back again to our question, when is a parent an authorized user of a child's health information? When a minor consents for his or her own health care, HIPAA says that a parent's right to inspect related medical records depends on state law. And if there's no specific state law addressing parent access, providers can use their professional judgment to give parents access or to say no to parents. So we know that generally parents have a right to access records when parents consent to the care, but there is provider discretion. We know that when a minor consents for his or her own care, HIPAA is telling us that parents' ability to access is going to go back to state law. So let's look and see what state laws we have in place. Now, these slides are just some examples. I urge you to go back into the toolkit and sort of look for more depending on the types of services you provide. But just as some examples, there is explicit state law prohibiting parents from accessing Title X Family Planning Service records, most kinds of drug treatment records for minors, records when minors seek diagnosis or treatment for sexually transmitted infection. Because we have law explicitly prohibiting parents' access, that means parents cannot get that without having the minor's written authorization. There are a few laws that allow minors to consent but obligate providers to give parents notice that their child is seeking these services. It's not quite the same as access to records, but it's important to keep in mind this notice provision and how you will incorporate that and distinguish that from access to full records. Here are examples of places where Colorado law explicitly gives providers discretion to give parents access to information even where the minor consented to their own health care. So when a minor seeks mental health services on their own consent, Colorado law gives the provider discretion to decide whether to share the records or not with a parent. Similarly, when a minor who is under 16 seeks HIV testing or treatment on their own, the provider is not obligated to tell the parents or give them access to records, but the provider has discretion to do so. When the minor is 16 or 17, the provider has to keep those records confidential from parents unless the minor gives them explicit authorization to share with parents. So as you can see, there's a lot of rules, and it really requires you to go back and look at the types of services you're providing to figure out who the authorized user is when it comes to specific types of information. So takeaways, and I know you're going to have to sort of go back through this stuff, but when a parent or guardian consents for care, parents generally have a right to access the information, but providers do have discretion to limit parent access. Minors generally can only access their own records with authorization from the parent, and parents generally authorize others to see or not see those records. Now there's other issues, custody, temporary authority of other parties, for example, a foster parent or the court or a social worker, depending on how relevant that is to your practice, that those may be issues that you need to delve into more with your own legal counsel, but these are sort of the three main takeaways. When a minor consents for care, minors have the right to authorize others to see or not see their records, and generally minors have a right to access that information. And when it comes to parents, you have one of three answers in terms of our parents authorized users, depending on the type of information or the situation. One option is yes, parents have a right to access the records unless providers exercise their discretion to turn that access off, or no, unless providers exercise their discretion to turn that access on or the youth authorizes it. The third is no, providers don't have discretion to decide whether or not to give parents access, and the only way parents can get access is if the youth authorizes it. So that was a super quick overview of our HIPAA security and privacy rule. Once we sort of have a sense of who is the authorized user, and by that I mean who can access the personal health information online without needing permission from a third party, or who has the right to turn it on or off, there are another set of questions that we need to look at that I sort of put in the practical, which I call practical, and that's just me, and those sort of are triggered by understanding who the authorized user is. So if a patient portal will contain personal, individually identifiable health information, HIPAA requires you to implement what it calls reasonable and appropriate administrative, technical, and physical safeguards to protect the confidentiality of that information. It requires you to make that information available on demand to that authorized user. And it requires you to implement reasonable and appropriate policies and procedures in written form that document how you're going to meet all of these obligations. And that's what you all have already done or are in the process of doing. So that's great, but this is also where in order to implement these, we start talking about, do we need to have a way to segment or segregate different pots of information depending on who the authorized user is? If we are providing online access, how do we authenticate the user and make sure that users have access to the parts they're supposed to and don't have access to the parts that they're not supposed to? So in that way, it's sort of the practical stuff. And if you have something like provider discretion, how do we, in a practical way, implement that ability of a provider to enable or disable, or in other words, suspend or discontinue access when a provider thinks it's not appropriate, for example, for a parent to see a record or believes that in this case it is important to see that record. So this is where it's sort of circling back, and when we think about which of these different components actually would involve individually identifiable health information, again, the practical rules we just talked about are only triggered when those components will be sharing or possibly disclosing in some other way individually identifiable information. And so this is where I want to go back to our two cases now. So our first case, Joe, who's 17, and his mom, again, they went to the clinic. He got a general physical, so presumably there's some information in his record that his mom consented to. Maybe he got some immunizations, had sort of the blood work, etc. But he also got an STD test, which is, we now know, a minor consent service. So it was appropriate for the clinician to work privately with Joe and to do this test on his request. And now our clinician has emailed Joe and told him his results are ready, and sent him a link to some anticipatory guidance and information. So looking at the information we have involved, first we have a lab test that was performed. We now have results. We have possibly billing information. We have clinical notes from the clinician. Some relate to the general physical, some relate to the STD test. So to the extent that they are going to use an online portal to make available the actual results of a test or any of those components, they're going to need to think about how can they segregate the records related to the STD test from the records related to the general physical, and make sure that the authorized user in each case can access what they have a right to access to, and don't access the stuff they're not supposed to. The email, secure messaging, certainly the email is disclosing individually identifiable personal health information, so all of the rules that we just talked about need to be put in place with any secure messaging system. We need to make sure that only Joe has access to those messages if they're going to be sharing information about, for example, an STD test, because parents are not authorized to see that without Joe's permission. Sending anticipatory guidance. It's really important to think about what does that mean. If they're sending a link to something about gonorrhea, is that effectively disclosing individually identifiable personal health information? Or if they send him a link to a broader web page that has information about all sorts of stuff, is that disclosing individually identifiable information? There may be ways to use that don't disclose information or that do, and thinking about which is valuable for your client and which is sort of more practical for you is really important. All right, now going to Miranda. Again, she's 12. She received mental health counseling. During a private conversation, she's revealed some information about her father getting very angry. We now know that her parents have split up, and she lives with mom and grandma, and dad is asking to schedule appointments and to ask for a copy of her file. We haven't talked about whether any of this is online, but this certainly raises the issue if, for example, the clinical notes or any of her record were online. Making sure we understand who the authorized user is very important. If there's an issue of custody here, how do we know and implement that quickly and appropriately? But let's say dad does have a general right to see this. How do we make sure that that provider discretion component is also something that is implementable, for lack of a better word? Is this a situation where it may be better for dad not to have access to the full record? And if so, how do we do that if records are in an online system? Okay, and that sort of brings us to my third P, the principles. even if we know how to do a lot of this stuff, is there some information that's better handled in person? So for example, emailing Joe and telling him his results are ready, but asking him to come in for that face-to-face conversation. Just sharing some information require context. So Dad, in Miranda's case, is it better to have a conversation and find out what he's looking for in the record? He says it's to bring to school. Is there certain information that he needs as opposed to access to the whole thing? Is there some way in that sense to make certain information available online but not everything? In the research that I mentioned up front, these were some of the questions that parents and youth had as well. How do we provide context if we are getting information online? And going back to, in looking at our principles, going back to our core goals of making sure that we're promoting better outcomes and better access to care. In that sense, which of these tools and sort of how we implement them will actually foster improved outcomes. And that's, as I said, what we heard in the research. So there's a phrase that a mental health clinician I know loves to use when he talks about confidentiality. Just because you can doesn't always mean you should. So in this case, the teen said, would you want to get your test results online? Well, I might not understand what the results meant, and I'd need to ask my doctor to explain them. Or I'm concerned that doctors won't keep this information confidential and will mention it to parents. So even if you have all of these wonderful confidentiality tools in place with your portal, will your clients understand those? The fact that they can get information online, is it going to scare them because they don't understand how protected it actually is, and is it actually going to backfire on us? And then there were concerns from some parents and teens that there are certain conditions or types of services that it's quote-unquote inappropriate to discuss online. They didn't actually go into a lot of detail about what that meant, but that is, again, important to make sure people feel comfortable and take advantage of what you're providing to them. Okay, so with that, I'm going to pass it on to Tom to talk about how you take all the mumbo jumbo I just said and turn this into action.
Hey, Rebecca.
Yeah.
Sorry, Tom. Sorry. Hold on real quick. We did get 3 questions, so it might make sense to answer them now before I have you pass the baton. Would that be okay?
Sure. Okay. So
the first question is, are there examples of privacy HIPAA compliant written procedures to share?
I actually would look to Tom and Jim for that. That's an example of where, because those are so often something that's specific to an agency and is often worked on in conjunction with legal counsel, I don't provide that because I think it is important. It can sometimes be something that's been negotiated with legal counsel, but Tom and Jim may have something that they could share. I don't know.
Okay. Tom, you can answer that when we turn it over to you. There was a comment, even if we are able to ensure the confidentiality of adolescent care, the insurance companies and CMS sends the EOB to the parents, thereby negating confidentiality.
Yeah. So this is a huge issue, particularly now with the Affordable Care Act and more folks in a great way with access to private health insurance. And the issue is when you, whether you're a young person or an adult, are insured on a health plan that's in someone else's name, so a partner or a parent, it's very common for the insurer to send billing information or an EOB to the owner of the plan that outs confidential care you receive. So even though your provider is not able to tell parents, the insurance company through this back end tells parents. That's an issue actually that I could talk a long time with you about, and we actually have just passed a law in California to address that, and I know a number of other states are looking at doing something similar, but that's technically separate from the portal, but it is except to the extent that you have billing information on your portal. So I love that you raised that, and if there's sort of a way that you're using it in your portal that you want to talk about, I would be happy to. But I also would be very happy to talk to folks outside of this if you want to hear about what the law in California and some of the other places, sort of the strategies that people have been using in other states to address this EOB problem.
Okay. And then the last question is, how does one create that important segregation between what Joe will see and what parents can access without double charting?
Yeah, that's a great question. So HIPAA itself doesn't mandate you do it in a particular way. It requires you to implement administrative and technical safeguards so that you're able to distinguish between the records, the STD records that Joe controls and the records that parents control. But how you do that is going to depend on your clinic and the capacity in your clinic. Some people really do double charts. Others have systems that allow them to put in place filters or tags. There's, huge hospital systems can do things that perhaps a smaller clinic can't. And so it's difficult to give you the perfect answer. It's really going to depend on your agency and its capacity and its internal systems. I know some places, unfortunately, have to send this through their legal counsel's office, and they have them manually do that, which is not a great solution. But So I just mentioned that because it's definitely something that I think there's no perfect answer yet.
Okay. Well, thank you so much, Rebecca. And sorry, Tom, turn it over to you now.
All right, not a problem. Thanks, Rebecca. Regarding the question about the availability of examples, I have several things that I've consulted in preparing the presentation today, but I don't have authorization to share them. I'll work on that and get some. Jim may have some examples from some of the organizations that he's working with. We'll both work on it, and when we get them, we'll put them up online in the SharePoint site so that everybody has access to them.
This is Jim. We have a couple of resources that are there right now that are more patient-facing. An example, minor proxy brochure that I actually have as a member of a group called University Healthcare Alliance that has good frequently asked questions and a good approach to how one shares with parents what they can, why these rules exist, and and how the portal is set up to address them. And then I have a news release with an extensive article written on when one group named Sutter here in the Bay Area of California launched what they called My Health Online for Teens, and exactly what they released and didn't release. So that's the kind of information we have in there now. I do not have specific portal policies related to minors, where one would expect to see in a policies and written procedures kind of format. I don't have that.
And can I just say one thing? The one thing I'd add, if you're looking at a California example, is that the minor consent laws in California are different than those in Colorado. So you would have to keep that in mind if you were looking at that as a model that you're using to replicate.
Yep. Thank you for saying that. Yep.
And we will work to pull together examples, and we'll bring them up to the resource site as soon as we get them. And thanks, everybody, for your questions. Keep the questions coming through the chat window. And after this we're on the last part of the presentation now. After this portion of the presentation, we'll go into more question and answers. So if you've got questions, keep them coming or be prepared in about 10 minutes. So our intent in presenting the webinar is to offer you practical information about minor access to patient portals, information that can be turned into action. We're asking you all to take some small steps after this webinar with the goal of better understanding your current patient portal policies and looking at whether or not your organization would like to expand minor access. So at the end of this slide deck, we'll ask that you start a process. We're keeping it rather short and confined so that we know that you're all in different places with your portal implementations, and some of you are going to have more time to put into this issue right now than others. But we'll ask you to do some small things that'll move you forward. What we'll do as well is hopefully as you're doing this in your organization, more questions will arise. We'll ask you to share those questions with Jim and I, and Jim and I will pull those questions together and share them with Rebecca. Rebecca and I will work together on an agenda for the second Minor Access webinar, and we'll use the information that we gather from you to build that agenda and to provide you deeper information in the areas that will really help you. And we'll announce when that webinar will be scheduled shortly. So the right place to start with your examination of kind of how to proceed is with your patient portal team. You've got a multidisciplinary patient portal team, and you need that multidisciplinary aspect in order to move forward with the portal project. You may also need to reach out to your leadership team when it comes to kind of setting policies within your organization. And next slide. Okay, there we go. Sorry. So it's one thing that's important to know when you're working in this area is that you really need to think about alignment, and this goes with much of health IT. In the case of minor access, your clinic's strategic goals must be aligned with the federal and state laws, the capability of your EHR and portal systems, and clinic workflows. So it doesn't matter if you have a policy that can't be implemented because it doesn't comply with any of those other areas. If your portal won't support it, then you don't have an actionable policy. So it's really important to kind of to think in terms of using the capabilities of all your portal team. What can the portal and EHR software produce? What's reasonable from an operations perspective? What's reasonable from a clinical perspective? And you know, where do we go as an organization? Where do we want to proceed? So all those things really have to align. And there needs to be somebody who's and presumably the portal team would take some of this role, but to provide oversight to make sure that these are all kind of fluid areas. Your portal is always being updated. The laws can change, and you know, your organization's strategic goals can vary. So somebody really has to make sure that alignment is in place and being done. Step one is to really understand kind of what your current portal policy is, and to really look at it and say, is it aligned? Do we have the policy documented appropriately? Does it represent our strategic goals? Does the EHR portal system give you the functionality that you need to meet those strategic goals? Is it configured appropriately to do so? Are there features and functions in your EHR portal that that could be leveraged more appropriately to meet your organizational needs? Is your current minor access policy within state and federal laws and regulations? Are workflows in place to support the solution? Are staff appropriately trained? Are training materials made, documentation made available? Does the solution impact productivity in a way that's unacceptable or unsupportable? Is oversight in place to make sure that the solution is always working? That first step we kind of expect everybody to do. Now we get on to the second step, and it's really kind of, if your portal, if you feel like your organizational policies, if you want to make minor access available to a greater extent than you do now, then really you need to kind of dig into step two, which is to determine the level of access that you want to give. And this is where you might want to reach out to leadership. Each organization will do this in their own way, but organizational leaders, clinical leaders, and members of the portal team are valuable in making this work. We've as Rebecca pointed out, we pulled the quick reference chart out of the Understanding Consent and Confidentiality in Colorado, and we've sent both of those out. We're going to also resend them at the end of this presentation to make sure everybody's got them. But that quick reference chart is going to be invaluable in kind of helping people to conceptualize what can be done and what could be done. Don't forget when you're discussing what features and functions you want to make available to minor users that you think about those areas that don't include PHI. Rebecca referred to how to make information available, like sending a particular piece of information may create an issue, may create a PHI, but if you send somebody to a page that contains 30 or 40 resources crossing a wide variety of areas, it may not. So that's something to consider. And then also just remember what we talked about with alignment. The solution that you come up with must be feasible. So aligning your organizational goals with what can we really realistically implement at this point is important to think about. Rebecca, I want to throw it to you. Do you have any additional thoughts, especially kind of relating to that ePHI?
Actually, no. I think at this point I don't. I just really would highlight that, making sure you flag that difference. And I think the next slide that you're about to get to is particularly important on the age range. So I'll leave you to that one.
Got it. So step 3, once you've kind of decided what it is that you want to offer, then the next step really is to turn it into a policy that reflects how you're going to actually be able to do that. This really kind of documents how you're going to do it within the realities of your portal system and what can be done. And I'm going to move to the next slide before I get your input again, Rebecca. Your patient portal policy really needs to include who signs the consent, or who's the authorized user, who's issued the login for the account, what are the exceptions for this portion of the policy, how are parents notified when access to their child's record changes. If you're going to sequester the record into 2 parts, who has access to which part? And again, in the bulk of the policies that I've looked at and worked around, thinking about them in terms of the age range and service provided is and then answering all these questions for each of those age ranges and services provided and status is important. Now I'll throw it to you, Rebecca.
Okay, thanks. I just want to go back on the bullet points you have, who signs consent, and Tom already mentioned this, but I just really want to, it's so important to sort of keep in separate pots who's consenting for the health care, so what does the law say about who is allowed to consent for the health care, who the authorized user is. Often that will be tied to who consented, but not always. As we saw, there may be times where parents have a right to records about services minors consented to. And then a third component is who signs consent to use the portal. I know some programs, and not all do, actually require their clients to sort of sign a permission and say which components of a portal they want to use. HIPAA doesn't require you to do that, but if you do that, it's just really important to keep in mind that you don't want it to trip you up and give parents the right to opt their children out when the children may actually have rights under HIPAA to get that information anyway. And if you are creating adolescent access, how do you get to the adolescents to talk to them about creating their own user identification, making sure that it's separate from parents? So it's important to really pull apart that consent question. There's a lot in that, and it ties back to the who's issued that login and how do you do that in a way that keeps youth information separate from parent information.
And Rebecca, can you talk a little bit about the kind of maybe some of the benefits and challenges of sequestering a record or breaking a patient's medical record into a minor patient's medical record into two parts?
Well, we talked about that a little bit earlier. In an ideal world, we'd have the ability to flag or segment information, having it really in what people might call as two different records is the safest way to make sure that a person, a provider, is using their discretion to segregate records and that nothing is sort of accidentally infiltrating one or the other, but it definitely is asking your providers to take on more work that they are not, and do record keeping in a way that they may not be used to. If you have the capacity to put in an electronic system that can read through what might be an integrated record and pull out information, that's fabulous. But we know that that for many people that's just not something that's in the realm of feasible right now.
So that's really part of how you would develop your policy, is really to kind of, you can't just do it in a vacuum. You have to look at what your system will support and what your system won't support, and look at the implications on workflow.
Absolutely. On your clinicians and what clinicians are currently doing.
Absolutely. So key points to consider. Information from some protected visit types cannot be provided to parents of minor patients. Rebecca's done a great job of laying that out. And then, it's going to really, how you lay this out is going to be based on the capabilities of your EHR and portal software solution. Step 4, once you've developed that policy, then it comes time to implement. And really you want to consider carefully looking at all aspects of the implementation, including how you're going to make this policy come to life given the functionality that you have to work with. Allocate time for testing to make sure that the system is reacting in the ways that you anticipate that it will. Look at where changes to workflow are necessary, where they're required. Look at the training and materials that have to be developed to support those workflow changes. And then consider how you're marketing to minors, whether you want to market differently or change how you're reaching out to minors based on the new policy. And remember at this point too that this is really your last chance to evaluate what you're doing and look at those issues of alignment and make sure that the solution that you're going to implement is appropriately aligned going forward. And then, just given the amount that's on everybody's plate, look at how realistically this is going to, what kind of effort it's going to take to implement changes in a minor access policy. So the assignment for you, we're really asking everybody to do step 1, which is, hopefully it's relatively simple. It's understanding your current minor access policies, determining whether or not they're aligned with organizational strategy, looking at how they fit with EHR and portal functionality, Colorado and national laws and regulations. Especially ask, is your policy, is your current organizational policy reflected in your written minor access policy? I think that exercise will raise a lot of questions on its own. For the folks that look at that policy and determine that the policy does meet what your organizational intent is for minor patients, then the next question is, is the rest of the policy aligned? If it's not, then that's something that you would need to work on and make sure that it's in place. If you feel like after this discussion, after the kind of the case that Rebecca made for providing access to a wider access to minor patients, if you feel like a change is important in your policy, then we'd ask you to kind of move on through steps 2 and 4 before you get to implementation. And we're really hoping that that phase 2, the second webinar that in this series, will deal with the questions that are generated as you start to dig into this work. So we've already heard that people want access to example policies, and we'll work to make that happen. But what other questions are you running into? What other issues are you running into? Feed them back to Jim and I, and we'll feed them back to Dara, and we'll develop that agenda for the next webinar that will go deeper into detail in those areas that you have questions and concerns about, and we'll address them at that point. And we will alert you when the second webinar is scheduled.
Work on your plate, and I just want to take a quick moment to sincerely thank you for participating today in this third peer learning community webinar focused on providing minors with access to their health information through patient portals. I know this is an area of great interest across our participant community and hope you find today's webinar valuable. We've got a lot to cover, but before I turn it over to Tom Dawson with Full Circle, I wanted to quickly go over a few housekeeping items. Our webinar today is being recorded so that others who could not attend can watch the presentation later. Tomorrow you will receive a link to this recording. We'll also post the recording on the patient portal resource site. Further, in order to minimize background noise, your phones will be muted in a listen-only mode during the presentation. The final portion of our webinar is devoted to questions, so please feel free to send your questions via the chat function at any time during the presentation. We will also answer questions as they come along as well. So, again, please feel free to send them all throughout the presentation. You should see a chat area, a chat dialogue area located on the lower left-hand side of your screen where you can type and send the questions. You will also see a raised hand button, and we're not going to use that during the course of the presentation, but at the end for the Q&A, we will be using that so that we can open it up over the phone, and people can have more of a conversation and an opportunity to share any information that they would like. So we'll extend beyond just chat functionality at the end during the Q&A session. If you do have any technical difficulties during the webinar, please call ReadyTalk toll-free technical support number at 1-800-843-9166. That's 800-843-9166. And make sure you have your registration confirmation available. And then finally, when the webinar is completed, you will have the opportunity to give us feedback through a short survey. And we really ask that you take a minute and complete the survey. And this will help us make sure that our future presentations are valuable. So with that, I will turn things over to Tom.
Hi, everyone, and thanks, Dara. Today we're going to review the content presented in the first Minor Access webinar, but we're going to go into greater depth on topics that have been selected based on your feedback to us. In the first item on our agenda, Rebecca will be presenting key factors involved when establishing, revising, or documenting a patient portal minor access policy. Then Rebecca will review the impact of HIPAA regulations and Colorado law on minor consent. After that, I'll discuss some practical considerations in the development and implementation of minor access policies. After that, we'll begin the Q&A. I ask you to begin formulating questions now, and as Dara said, you can enter them into the chat function right now as we speak, or you can wait until the slide presentations are over. Think in terms of where you're at with your current minor access policy. Are you evaluating it? Are you happy with the policy as it exists? Are there concerns about aspects of your current policy? Do you wish to expand portal access to other minor patients? Think in terms of the practical things that you would like to accomplish and bring those questions up. As a caveat, Rebecca won't be able to offer legal advice. Only your counsel can do that. We're also not going to get into great detail on vendor-specific issues, but I would ask you to keep those vendor-specific questions at hand. We all either have or will be scheduling shortly check-in calls next week, and on those check-in calls, we'll prompt you to see if there are any vendor-specific questions that you have, and we'll work on solutions for them at that point. Now I'd like to turn it over to Rebecca. Rebecca.
Thanks, Tom. Hi, everyone. Thanks again for joining us. So as Tom noted, I'll be doing sort of a quick review of some of the content that we discussed on the first presentation, but we've really actually made this fairly high level and fairly short to make sure that we have a lot of time not only for questions but conversations and sharing ideas among each other at the end. So, for some folks, this is already going to be too much of a review because you're already there. For others, this may feel like I'm not doing enough. We're going to have plenty of time for conversation at the end, though. So hang on, and we'll get to that. But let's start by just taking a step back. And really, when we boil it down, when you're developing your policy, there's three questions that sort of that the legal issues turn on. And the first is actually considering, separate and apart from law, which portal functions will foster access and improved outcomes, which are actually going to further your goals as a health institution. Once we have that list, we ask which of these functions involve PHI, protected health information, and where they do involve PHI, that's when we have to get into some of the legal questions. So let's walk through each of those. At the highest level, we're talking about which portal functions you may already be using or may be considering, and deciding which ones to use. And it's actually an important question to sort of settle on and talk about. As we saw in the last presentation, there has been some research both with parents and with teens in which they've overall expressed great interest in portals. But for certain functions, there have been questions raised. We know that in one of the studies that I presented, some of the youth expressed concern that certain kinds of information, if it were presented via a portal, would it really be confidential? You may know that your system can keep information confidential and that you can keep parents away from information that youth may want to keep private, but does the youth trust that? Even if you can, should you, given sort of the way they understand the system's work? Are there certain kinds of information that really are better provided in person, in which a clinician or another kind of counselor can provide context to the information? So thinking through those portal functions, and even if you have the technical capacity to include them, does it make sense given your population, given the types of services you're providing, given the concerns that your clients and patients may be expressing about access to information? So once you sort of walk through those discussions and created your list of sort of wish list of this is what we're hoping to do, our next question is which of these functions involve protected health information and which do not. On the last call, we talked about whether some of the functions that folks sometimes flag might not require you to disclose electronic individually identifiable health information. We talked about, does something like providing health information and guidance on a web page trigger PHI? Is there a way to do appointments or somehow do messaging with clients that doesn't trigger protected health information? The only way for us to sort of sort out what triggers PHI and what doesn't is to go to the definitions in federal law in the Health Insurance Portability and Accountability Act and see what is considered PHI, and then go back and look at sort of the functions that we're considering. And again, the way that you are considering providing health information via your portal may look a little bit different than your colleague down the road when they're envisioning it, or when you're looking at sort of your vendor, the way they do it. So there's not just one answer for health information guidance up on a website is always disclosing PHI or not. It really depends on how you implement it. So let's look at that definition of protected health information. PHI, protected health information, is called individually identifiable health information, so you can trace it back to that individual patient, that is transmitted by electronic media, maintained in electronic media, or transmitted or maintained in any other form or medium. Pretty unhelpful definition, but we can then go in and look at the definition of individually identifiable health information, and I think this is where it's going to resonate, and you're going to really be provided the tools you need to sort of go back and look at the portal functions you're considering and make a judgment call with your legal counsel and among your agency administration about whether you think this is triggering PHI or not. So individually identifiable health information, as defined in HIPAA, is information including demographic information that is created or received by a healthcare provider, health plan, employer, or healthcare clearinghouse, and relates to the past, present, or future physical or mental health or condition of an individual, the provision of health care to an individual, or the past, present, or future payment for the provision of health care to an individual, and identifies the individual, or with respect to which there's a reasonable basis to believe the information can be used to identify the individual. On that second one, the idea is that even if you don't provide, for example, a name linked to information, if there's enough detail that it can be traced back to one person or a small group of folks, that would be sufficient to trigger this definition of individually identifiable health information. And that's really important because one of the questions that has come up is, let's say we send a link to a patient that says, here is health information about chlamydia. Would providing that link to this individual person be sufficient to trigger PHI and say that we're conveying PHI? As Tom said, I can't provide legal advice, so I can't sort of sit down and say, yes, this does, yes, this doesn't. All I can do is provide legal information and the tools to make those decisions. So the key is sitting down and looking at the functions that you're considering, the way that they've been set up in the technology that you're using, looking at this definition and seeing if you think that this does in fact trigger PHI in the sense that it's information relating to past, present, or future physical or mental health, provision of health care to an individual, or past, present, or future payment, and either specifically identifies the individual or provides sufficient information that someone could use it to link back to an individual. So as I said, we can then sort of walk through some of these. We know, for example, providing lab results or personal health records, that is going to trigger PHI. Secure messaging, depends what kinds of messages you're sending. You would have to go back to this definition and make a decision. Online appointments, is that sufficient to say that we are relating to past, present, or future physical or mental health condition of an individual? Includes identifying information. That's for you to make your judgment call. But let's assume that at least some of the portal functions that you are considering or interested have already implemented do implicate personal health information, protected health information. If so, that means we have to go to our third question because when PHI is involved, it means that we have now triggered the requirements of both the HIPAA security rule and the HIPAA privacy rule, and both of those rely on Colorado law to help define the specifics of what we need to do. So for any of the portal functions that you have determined do not trigger PHI, you don't need to worry about security rule, privacy rule. You can implement them without needing to consider the legal parameters. The ones that trigger PHI, we need to now look at the security rule, look at the privacy rule, and look at Colorado privacy law. And one of the first requirements of the security rule that we should flag is that HIPAA actually requires you to develop a policy and protocol for your use of electronic PHI. So not only is creating a policy a good idea, it actually is required by federal law once your portal is or in use of electronic records is triggering PHI. So when we look at the rules that are included in the HIPAA security and privacy rule, and we reviewed them in the last training, so I'm not going to go through each of the different aspects of that. But what we know is that much of the rules and sort of the triggers go back to the question, who is the authorized user of this protected health information? And the authorized user really boils down to two questions. Who has a right to access this personal health information, and who can authorize its release to third parties? And this is where we then go down into Colorado law. HIPAA defers to Colorado law. And we know when we're talking about patients who are minors that when a parent consents for the minor's health care, parents generally have the right to access health information regarding their minor child. But there is this important caveat that gives providers discretion to limit parent access in some circumstances. In general, minors can only access their own health information with authorization from the parent or whoever, the legal guardian, whoever owns the legal rights as authorized user. And we know that parents generally have the right to authorize others to see or not see the information. So in some ways it's pretty clear cut when parents consent for care, but we do need to keep in mind that there are situations where parents might have their legal custody removed or limited, where a court or others may authorize third persons to consent for care if a youth is in the foster care system, if there's been a guardianship set up. So even when we're talking about what seems like a fairly straightforward access, there needs to be something in your policies that addresses what to do in these unusual circumstances when a parent may not have custody or when your providers may believe that access to records is not appropriate. The second issue would be when minors can consent for their own care. We reviewed this in the last training and provided some handouts, but there are some situations in which minors have the right to authorize their own health care. In general, in those situations, minors have the right to authorize others to see or not see their information, and generally minors have the right to access the information. One of the big questions, though, when minors are consenting to care is what about parents' access rights? What are the rules there? And that will depend on the type of services being provided. And there's really three different kinds of answers. For some kinds of services, even if the minor consented, a parent will still have the right to access unless the provider turns that access off. In other situations, the default is that parent won't have access unless the provider exercises discretion to turn that on, or the youth authorizes the parent to access. And then there's other situations where the youth really controls access, and it's only if the youth authorizes a third party, including parents, to access that they would be able to see that information. So we know that when it comes to minor consent services, how we handle PHI is a little bit trickier when we're talking about portals and functionalities. So I thought it would be helpful for us to put this into action by walking through sort of the life of one patient and see how this might implicate different functions. So we're going to be talking about Luisa. Luisa is starting out with us as a 5-year-old, and she's a new pediatric patient at your clinic. Angelica and Jose Luis are her parents, and they've brought her in for her annual physical. Because you all have already implemented a portal, when they bring her in, not only are you doing the physical health services, but you've offered the parents the opportunity to create this online account via the patient portal that gives a separate user ID and password for Luisa. So our first question is, who is the authorized user of Luisa's health information? So going back, when we look at our general rules, when parents consent for care, parents are the ones who both have a right to access health information regarding their child, and they also have the right to authorize others to see or not see. So in this case, for 5-year-old Luisa, all our information indicates that her parents have legal rights to consent for her care, so they would be the authorized users, both of them. So which portal functionalities can her parents use? Even if we're talking about functions that trigger the use of protected health information about Luisa, her parents would be legally the authorized users of those functions on her behalf. Now, one of the questions I thought it would be interesting to throw in here is, which functionalities could Luisa use? So this is one of those cases where, I mean, she's only 5 years old, but Luisa technically would need her parents' permission. She is not an authorized user of her care because her parents consented to the care, and in order to access her own health records, she would need her parents' consent to do that. So she would not automatically have a right to see her protected health information. And considering some of the, a 5-year-old, probably that's not something we want to worry about, but as we're talking about clients as they get older, that would be something to think about. Okay, so now let's move on. Luisa is 8. You have, as part of your portal, the ability for folks to schedule appointments online. So you know that somebody, we don't know who, has scheduled an appointment for Luisa. We assume it's one of her parents because they're the only 2 authorized users that you've set up with accounts. So she shows up on the day of her appointment with her father, Jose Luis. He explains that she's had an earache and been complaining of stomach pains. He also tells you that he and Angelica, the mother of Luisa, are no longer together and that in fact he has legal custody of Luisa now. So now our question is, who is the authorized user of Luisa's health information? And what does that mean for the portal and its functionalities? And again, our general rule is that a parent or legal guardian is the authorized user under HIPAA of Luisa's health information. That means they have the right to see the information. They have the right to control who has access to it. But now we have this information that perhaps mom no longer has legal custody. And so the question for you all is, when you have this kind of situation, when that information, it's probably, Jose Luis has probably mentioned that to the clinician, what does that mean for the portal? What are the affirmative steps that you would need to take once you know that one of the people who formerly had access legally does not? Do you need to ask for a copy of that custody order? How are you going to proceed? And unfortunately, I can't tell you what to do because that would be legal advice, but I can sort of set up that question and how are you going to address it, and how does that information flow when the clinician may be getting the information, maybe it's the front desk. What do we do? Okay, so you're at the appointment, and Louisa's clinician has looked at her ear and has prescribed an antibiotic. She also has referred Louisa to see one of the mental health clinicians at the clinic. She's concerned that the stomach pains may be a side effect of some anxiety that Louisa's having, perhaps as a result of the situation at home. The healthcare provider says that there's going to be some more information both about the counseling services that your agency provides and about the antibiotic and side effects and what to look for available on the website, and that you would be sending a link, the clinician will be sending a link to that information via the portal and secure messaging. So again, what does that mean for the portal? We've already talked about who the authorized user of Louisa's health information is. There's no problem sending that information to the person who has legal custody of Louisa, but if mom still has access, does sending this information via secure messaging or via the portal, does that somehow violate your obligations under HIPAA? Do you need to make sure you've turned off mom's access before you send that information? These are questions for you to discuss with your legal counsel and with your vendor. How do you implement that sort of walling off of those who no longer should have access? So now we've jumped ahead, and Louisa is 15. And she's come in again for her annual physical. Her father consents to that because it's still something that the person with legal custody consents for, since Louisa is a minor. And as part of that general screen, she has some blood taken. They're going to check a lot of things, including her glucose and calcium for different reasons. They have some concerns about that. And as part of her physical, the physician asked to meet privately with Louisa, which is part of the recommended process when we're working with adolescents. During that private meeting, Louisa says she'd like to be tested for some STDs, and she also would like to discuss contraception. We know that both of these services are minor consent services, so Louisa is able to ask for those services and conversations confidentially and on her own. So what does this mean in terms of authorized user? So who is the authorized user of Louisa's health information? Well, when we're talking about the general physical and, for example, the blood tests for glucose and calcium, her dad consented to that care. He has the rights to access the results and access the health information related to the general physical. And in that sense, he would be considered an authorized user for purposes of electronic health information. But the STI and contraception were services that Louisa consented to, and therefore she is the authorized user of that information. And we know that she is the one who both has a right to access that information and control the release of the information, including deciding whether or not her father or mother or other persons should see it. So what does this mean for the portal and its functionalities? Well, if you have put online, for example, access to lab results, we will have certain lab results that we know Dad is the authorized user of, and we know that there will be certain lab results, the STIs, that Louisa is going to control access to and that Dad should not be able to see without Louisa's permission. So when we're talking particularly about teenagers, how do we, if you're going to have online, for example, lab results, how do we segregate out those different types of services and results? When it comes to appointments, does simply making that appointment somehow trigger protected health information that one person's an authorized user of versus the other? As we know, this is really where the rubber meets the road when we're talking about youth who may have certain services that they're going to start consenting to on their own. Another question here, though, would be, let's say that Louisa has continued to receive mental health counseling ever since she was younger. In the beginning, her father consented to that counseling services and controlled access to the information. Louisa is now 15. We know that under Colorado law, 15-year-olds can consent to their own mental health services. So how do we handle access to her records? Is it appropriate to put all of the information about her counseling up online? If so, how do we make decisions about who should be seeing what? If we don't put the full record online, what kinds of information does it make sense to include, and who is the authorized user of that information once we have Louisa turning 15? Again, I can't tell you what to do because that would be legal advice, but just trying to frame some of the questions. Now let's say that the provider asked Louisa to come back for a second appointment in order to review her test results. The provider has decided that it's much better to provide some context and provide those results in person. But she tells Louisa that she can make an appointment online and recommends online health information on the portal. If she's simply recommending accessing this information, she's not sending a direct link to Louisa, is that triggering protected health information? Does that somehow trigger your HIPAA obligations? Or is just letting her know that it's up online in and of itself not something that triggers PHI? That's an important question. If she's setting up an appointment online, does the fact that she's able to set up an appointment on her own in and of itself trigger that definition of protected health information that we reviewed before? Even if the appointment isn't specifically laying out exactly what the services that she's coming in for, what she's intending to receive, does simply her ability to schedule that appointment trigger protected health information? Again, that's an important conversation and discussion for you to be having internally. So that's sort of the key questions, looking at the functionalities that you are considering including. You need to make a judgment call whether they might trigger protected health information, and if they do, you're going to need to determine who is the authorized user and how do we implement changes in authorized user, either due to legal custody, due to younger children turning into teens who can then consent to their own care. How do we implement provider discretion when there may be, particularly for some of the more sensitive information, a provider might want some control over who and how much information is accessed via a portal. And that really comes back to the question that I started us off with. Looking at the functions that you're considering, which of these will actually further better health outcomes? And in looking at that, questions to consider, is there some information that really it's better to handle in person, even if you can implement it via a portal? Or is there some information that may require context, or because of safety concerns of your clients, you choose to keep it as something that is shared in person alone? Is there some way to do a hybrid model? Rather than providing all information online, we just provide immunizations, we just provide messaging. Is there a way to balance these needs? And that ultimately brings us back to what is going to foster access and improved outcomes. Okay, so now with that, again, it was a really quick review. I'm going to pass it back to Tom. And
hold on, Rebecca, real quick. We do have a question that came in.
Okay.
If we already have a minor informed consent policy in place, do we need to have a separate policy specifically for the portal, or can we simply add language or an addendum for portal-specific situations? And would you suggest that we call out specific protocols for each portal functionality that could touch PHI, even if the protocols across functionalities are generally the same?
So there's sort of two parts to that question. One is what makes sense from a practical standpoint, and I would look to Tom to answer sort of what will lead to better results in that. In terms of legal obligations, what HIPAA says is that when a portal or any kind of electronic conveyance of protected health information is triggered, you are required to have specific policies that address how you're going to protect information as it's being conveyed. So when you say that you already have a pretty complete minor consent policy in place, I don't know exactly what that includes, but it would need to, if you are going to be implementing portal functionalities that will trigger electronic conveyance of protected health information, you're supposed to have policies in place that outline how that function is meeting the security and privacy rules of HIPAA. So I'm not sure how helpful an answer that is, but Tom may have sort of a better practical answer to that question.
From my understanding, it's fine if your minor access policy is part of your greater portal policy, again, as long as it addresses all the points that you need it to. It's maybe something that you want to have a heading relating to, but it can be part of your larger portal policy. As you may only choose to share portions of it with people at a time, so it does make sense to be able to have it be something that you can extract and share as necessary. So I'm going to get to the last few slides here, but I do want to let you all know that the question and answer, the serious question and answer period is coming up shortly. Feel free to put your questions now into the chat box, or hang on and we'll go to the raised hand protocol in a few slides. So the first steps in thinking about your patient portal policy, minor access policy, when you're developing the policy, you really want to break things down by age range and service provided. Who signs the consent? Who issues the login for the account? What are the exceptions? How are parents notified when access to their child record changes? And when records are sequestered into parts, who has access to what part? Those are some of the things that you want to consider when you're developing the policy and when you're documenting it. Key points to consider. Information from some protected visit types cannot be provided to parents of minor patients. We've kind of covered all that. Some EHRs offer functionality to sequester information, but every system is different and individual, and you really need to look at your system. You can create a separate record for minor patients, but that has its own consequences in terms of workflows, and everybody's concerned with not overburdening provider workflows. So again, it's something to consider within your organization. What's the most effective way to share that information? When developing your policy, a good starting point is to understand the current state of minor access in your organization. Is your policy accurately documented currently? Do you wish to expand minor access beyond what's being offered? And then you want to reach out to your vendor to determine what capabilities your system can offer. What are the system's strengths and weaknesses? Vendors should understand how their system's capabilities can be used and how they're being used by others to support minor access in Colorado. So vendors are a great resource. Sometimes it takes a little poking and prodding to get to the right person, but generally it's worth the time. Another option in that area is to reach out to others within our community or within vendor user groups for information on how there being able to effectively utilize the features and functions of your current EHR and portal products. Once you understand what's possible, then you want to discuss within your portal team whether your current policy is appropriate as is or whether it needs revision. If change is decided, then define the desired future state in a new policy and develop a project to implement the required changes. As Rebecca's pointed out, anytime you create or revise your minor access policy, you should reach out to your legal counsel to get their review and input. When the new policy is finalized and approved, then it becomes kind of a regular project where you have to prioritize the size of the project, the resources available, other projects on your plate, and workloads, and determine how to implement it. And as your minor access policy impacts multiple departments, the portal team is a great place to get started with these discussions. Portal teams will generally have organizational leadership, clinical leadership, information technology leadership, operations leadership, and those are the people that you're going to need to be able to have that discussion. Your policy needs to be clearly defined and documented to support consistent application of the policy. As you may have multiple sites, multiple departments, and multiple shifts, people coming in and out, it's important to have that documentation to be able to support implementation of the policy. Communication is required to explain the policy to staff, patients, and prospective proxy holders. Documentation will support the development of communications materials. We will have some examples of minor access policies that will be uploaded to the Resource Center next week. I'd ask you, if you have them, we'll prompt you on our check-in calls next week, but if you have a policy currently in place that's written, we'd love to see it, even if it's one that you're revising, so that we can add it to the Resource Center so that it can be used by other folks that may be at a different place in their portal implementation. And we'll have all those up in place sometime next week. So now it's time to move on to